individual patient information, since we are always record and podcast our educational events. And so I know you have a question you want to ask, but how do you like the format of?
I have up there is the agenda.
Mm-hmm. How would you like, to proceed with the format? Do you want me just give a quick presentation about how OLIF is done and then why is it different from other procedures, or what do you like to just jump into individual questions?
No, I think if you could go over the procedure of the OLIF, that would be helpful.
Okay, then I'm going to show you few slides. I have, so I have done probably hundreds of presentation in different venues for what OLIF is, why is it different. There is there are 3 presentations for physical therapists, occupational therapists, and Mike has the record of that. We will make sure you receive that. That is a full presentation about from A to Z and why is it different and how does it impact your job. For today, I would say, I'm just going to show you just 5 slides that summarize what is important, maybe 5 to 7 slides, but summarize what is important to you. I apologize, I have to open that presentation. I need 1 minute. But raise your arm if you have taken care of post-spinal fusion patient before. Everybody, almost everybody, good. So you're familiar with that how difficult it is sometimes to deal with them. It is sometimes, there are 2 kinds of spinal surgeries. One is so-called decompression, where we just take the pressure off. Those are considered smaller surgeries, but there are some procedures that we call fusion, where we take lots of bone material, disc material away, and we immobilize instrument and fuse 2 vertebral body together. Have you guys known for those cases that you have been taking care of, if there have been decompression or fusion? Can you give me a little understanding about what is if you take care of the spine patient, what category they are?
Some of both.
Both, really. We see both.
See both? What is the major difference you see in these 2 categories? Have you ever noticed that if one group can better work with you versus another? Have you noticed any categorical change differences in these 2 groups, fusion versus microdiscectomy?
Well, it seems like the more invasive the procedure, the harder it is to get them back, because they have to be immobile for so long, and everything gets weaker and tighter, and so you're starting in a bigger hole. So
yes, you just summarized it. And I'm going to put it in perspective for you. More invasive surgery. What do we do in a longer surgery? We cut. We stop the bleeding by coagulating the tissue, creating literally dead tissue. And then once the bleeding stops, we cut more until we are there where we need to be. So longer surgeries are by definition, and it's proven fact based on lots of studies, are more complicated. They have more morbidities, more even mortalities, more blood loss, more necrotic tissue, more infection. Shorter surgeries are obviously better. It is just has happened that fusions are longer surgeries. I'm going to share my screen with you here. Are you able to see my screen here?
Yes.
And I'm going to see if I can make it even a little bigger here. Now, this is a slide that I think you need to know, that every additional half an hour on the anesthesia adds 17% to the combined risk of the surgery. What it means is that if you put all the surgeries below 2 hours versus all the surgeries above 2 hours in 2 different groups, you are doubling the all the complications associated with the surgery. By the way, this is based on almost 400,000 patient data. So this is as statistically solid data as it can get. Now, who do you think, or what kind of surgery do you think is going to be more than 2 hours? Traditionally, fusions are always surgeries that, as a matter of fact, average one-level fusion in the United States is about 2 to 2.5 hours in non-academic place, and about 3.5 hours in academic places, one level. So, and you can imagine that the 2, 3, 4, 5 level fusion, this can be whole day procedures, and by nature are going to be more complex. But what do we do in that time? We talked a little about that. These are all the muscle in the spine that you are familiar with. In a regular traditional open fusion, TLIF, and I come back to that. For that segment that we do the surgery, we cut all those muscles. And guess what? Imagine your orthopedic surgeon repaired the shoulder, but then at the end decided not to reconnect the muscle tendon together. The shoulder will be physiologically practically unusable. One of the first 30 secrets of spine surgeon is that we cut the bone here. This is the spinal process. We cut the lamina, we cut the facet, and we strip the muscle off the bone, and we never connect them back. Did you guys know that? That spine surgeon never connect those muscles back to their origin? Many times we take the origin away. That is the meaning of laminectomy and facetectomy. Who did not know that we spine surgeon never reattach those muscles?
Why is,
I didn't know that.
I didn't know that until I started working here, but why do they not reattach the muscle?
Because we cut that the origin of the bone away, actually.
So
that-
there's no location.
There's no
to it.
location there.
You have to screw it.
Now,
Mm.
the second thing that we don't tell our patient is that vascularization of the bone is through surrounding muscle. Bone doesn't have its own vessel supply. What does that mean? When you strip the muscle away, you reduce the vascularization of the vertebral body to a 25% of the original value. Does that make sense that in that case, when you reduce the original vascularization of the bone to 25% of the original value, the recovery is going to be much harder. Your bone doesn't get enough blood supply to proceed with the fusion process or with the healing process. And it gets worse. When the muscles are detached, this is an MRI of the spine. Pay attention to the left side of each picture. You see here, this is the iliac crest. And here, just next to the iliac crest, you see this dark structure, that's the muscle. This is fat here. Now, paraspinal muscle on this side, does it look more like the muscle or does it look more like fat? It is scar. It is a vascular scar. Those muscles, once we strip them off, they die. Not only they die where we do the surgery, because the muscles are multisegmental, even 2 levels above, the multifidus muscles, which goes 1 and 2 levels across the segments, turn into scar. Practically, with the traditional scar spine surgery, we render spine physiologically dead. We kill the muscle, and then we send you the patient, we say, deal with them. So it is really not much to deal with once you remove all the muscles, you remove the bone that the muscles are attached, and at the end of the day, those muscles turn into this. This is a patient of mine in 2012. I did a 2-level TLIF. And in 2014, 2 years later, I did the adjacent segment OLIF. In 2015, patient hit a deer and I had to broke everything. I had to take the patient back. That is how this picture came to be. And where we did a traditional surgery, you may think this look good, but actually that is a vascular scar. That's why it's whitish, and this is physiologically dead tissue. All the muscle turned into scar. Whereas where I did the OLIF, this is viable, fresh, well vascularized tissue that you can work with. Let's go back to the traditional surgeries. PLIF is the posterior lumbar interbody fusion, where we go directly through the posterior. This is front, this is back. This patient is prone, meaning on the belly. We did it since 1950s, and then we discovered if we go a little to the side, we reduce the pressure on the spinal cord. It took us literally almost 30 years to figure out if we don't push on the spinal cord and the nerves, patient do better.
Isn't spine one of the slowest advancing?
It is actually, it is, because it is complex. It is more complex than almost any joint in our body. And this is a joke among neurosurgeons. Brain surgery is easy, spine is hard. And that all learning curve as well proved that after you have done 20 tumors, you're as good as you can be. You're still learning after you have done 500 spine surgery, you're still learning. So in 1980s, we started doing what we call TLIF, transforaminal lumbar interbody fusion. And guess what? This is still a 40-year-old car that we are driving. By number, 80% of the spine surgeries are TLIF. And there is a smaller version of that where we do less damage. We put like literally a tube, a bigger tube, and do the surgery through a tube. It's called MIS, or minimal invasive TLIF. And then there are other surgeries where we open up the belly from the front. By number, that is less than 5 to 10% of the cases. This is depending on who is your access surgeon. Can be a good surgery or could be a surgery you die of. Here in the University of Minnesota, happens all the time, everywhere in the United States, that if there are major vascular structure there, if you get into those vascular structure, you can bleed out. So it is a hit and miss. For that reason, by number, it really didn't caught up with the per number. Then there are ways to go from the side or from front and the side. By the way, this is called oblique lateral interbody fusion anterior to psoas, or oblique anterior lumbar interbody fusion. This is not what we are going to talk about. This is still true belly. Our procedure, two procedures are OLLIF, oblique lateral posterior lumbar interbody fusion, and minimal invasive direct lateral, where patient is prone, and we always use that border between the abdomen and the posterior, so we don't disturb any of them during the surgery. So because we are not cutting the muscle, we don't have to deal with all the scars created. You see, this is the abdominal muscle. This is the paraspinal muscle, used to be. This is not muscle anymore. And obviously, because we are not going through abdominal organ, I'm going to show you how busy abdominal area is. This is in a cadaver. In a real person, you don't have this beautiful thing. So you can imagine if your general surgeon is not really familiar with this or is not doing it daily, this can be a devastating surgery, abdominal, going through the abdominal cavity. I was very lucky. I was with a very good surgeon who gave me, within 30 minutes, access to the anterior approaches, for my anterior approaches. But I have been as well with people who needed 3.5 hours, needed to get the access and then abandon this access because they just couldn't get there. It's not a trivial thing. Now, the second slide that I want to show you is this slide that just, if you memorize anything from this meeting, is that spine is a common problem, but you know that. By the time you're 70 years old, there's only 1 to 2% chance you don't have spine problem. Some spine, they look like that. We do decompression there. We go there, just trim what's pushing on the nerve. But some discs look like that. Who thinks you can patch that tire? So by number, people are getting older. It's going to be a lot of people who their disc look like that. Those are people who need my help. Now, I want to emphasize to you that we have created a very comprehensive kind of protocols that surgery is truly the last thing that patient get. So meaning that long before the surgery, you are the front line of helping the patient so they don't need me. Now, eventually they are going to need me. And by the time they need me, let me tell you another story that there's almost every week a patient cancel their surgeries, come to us to get their surgery done our way. Once we put them through our protocol, they wouldn't even qualify for the surgery. We send you back to you. We send them to you to work, strengthen their paraspinal muscle, work on their posture, work on their daily activity. And these are important things we are going to come back to. There's a lot you can do. And these protocols that we have put together assures that truly I'm the last station for the patient.
So can you give us like a very brief, simplified explanation of the Olaf procedure?
So in the Olaf procedure, we talked about that problem is the disc. Unfortunately, the Lord didn't ask me when he was building human body, put the disc right in the middle of your body. No matter what direction you go, you have to go through a lot of tissue. You can go from the back, strip the muscle, kill the muscle, go through the belly, put them at danger. What we do, we literally put the patient on their belly, prone position. I use 2 C-arms. There is some mathematics involved there. There is a learning curve involved there. But at the end of the day, do you have a pen? Anybody has a pen there?
Yes.
That is the tube that I go to the disc is a little thicker than the pen you just hold up. Meaning that I utilize by using 2 C-arm here and using a trajectory that get me to a place that we call Cambin triangle. This place is almost like a size of your index nail of your index finger. And this was discovered about 40 years ago, but our technology was never good enough to do that. Guess what? This is like electric car. We in the United States discovered that. We neglected that. Chinese, South Korean, Japanese made a big deal of it. All the endoscopy you hear is based on the transcambina approach that was discovered and actually coined in Philadelphia. And now in the last 10 years is coming from Asia, coming back to us. This is equivalent of Prius, that we should have been creating that and using that, but we neglected that in the United States. I talked actually to Dr. Cambin about 2 years ago, 9 months before he passed away. He couldn't imagine that we can use this for fusion because technology that is really enable us to do that is tremendous, but we do it every day. I just did 2 of that today. So
Right.
it is a doable surgery.
So
Now,
you make a small incision and instead of cutting the muscles, you dilate, correct? And then you go in and take out the bad disc.
So the incision is by definition at an angle that you go at 45 degrees to the disc. And that pen that you just showed us, the tube is a little bigger than that. But first, we use a neuromonitoring probe that we are sure that we are not touching any nerve. That through that neuromonitoring probe, it has a sleeve over it, sleeve goes in, then a dilator goes in, open up the space, and then we put a tube in, and with the tube, we do the surgery. I'm hoping one day when we are doing those surgery, in smaller group, you come and watch that surgery. It is a very fast-paced surgery, and that's the beauty of it, because I don't cut the muscle, don't coagulate the, literally burn the tissue to stop the bleeding. Within first 5 to 10 minutes, my cages, my spacers are in. And then literally after that, and again, it is about the technology. It's not the one surgeon skills. It's truly a new technology that anybody can learn. We remove the disc. These are the content of the disc. And then look at that. This patient has a scoliosis. We put those spacers in strategic location to straighten the spine. And then over multiple small incisions, we put screws in. Look at that here. This is the incision where we go obliquely, you get to the disc, and these are small incision where the screws go in. In the L5S1, this skin incision is a little bigger because these 2 go through the same hole. In the L5S1, through the angle, so and people heal so fast from this.
And their bones do fuse.
Because we don't remove the muscle and attachment of the muscle to the bone, their vascularization of the bone is tremendously disturbed. So they grow in rates that's unheard of with open surgery.
So we don't have a lot of time left. What are the procedures that you're going to be performing at Summit Surgical?
Mostly OLIF, ACDFs, decompression. So
SI joint?
sacroiliac joint. Now, I'm a what you would call complex spine. I do anything from spinal tumors to craniocervical deformities to sacroiliac to scoliosis. But obviously, we are going to start with procedures that are, I would say, straightforward, less complex first. And then once we get comfortable with each other, then we can extend it and get to more complex kind of procedures.
So what are some of the indications?
Well, some of the indications are when the disc is let me make it very easy, actually. If your disc inside of you looked like this tire, that is the indication for OLIF.
What are some of the indications that Summit Surgical can look for?
Well, obviously, this patient, because the disc is gone, bone is on bone. They have horrendous back pain. In this group that we are here together, which of you had never had any back pain? Raise your arm. If you have never had back pain. Here you are. So everybody has back pain. Not every back pain requires surgery.
Right.
Most of the back pain, as a matter of fact, you just don't do things that provoke the back pain. The next step after that is maybe mild, non-steroidal and physical therapy. And physical therapy is something that every single patient of us get, as well occupational therapy, if appropriate. Now, the next step after that is after we do physical therapy and behavioral modification and avoiding excessive activity, is actually therapeutic injection. And we do a lot of that, where we go and to the nerves and put steroid there, put some local anesthetic there. And that process, again, summarized in our extensive protocols that make sure only less than 5% of the patient we go directly to surgery. And those are conditions that literally your spine is unstable. Like if you get progressive deficit, this is beyond this meeting, but we have developed this so-called Inspired Spine multidimensional protocol. It's like a card. You put the patient's symptoms, you give them number, like if patient comes with a progressive deficit and that progressive deficit is acute weakness or incontinent, then you have to get certain tests. If the symptoms and the test feed in a certain direction, then patient bypass everything, goes to surgery. But that's less than 5%.
Okay.
Actually less than 3%. Most of the people, once you give them those numbers, they fall either in the outside zone, which is all conservative therapy, or in consult zone, meaning that depending on your experience, you can get a consult or you can manage it, depending on if you have been doing 30 years physical therapy, probably you can treat the patient all the way to zone 1/2.
Sure.
Because, you're safe. But if you just started practicing like last month, is nothing wrong if the number falls within 3. And we give you, when we do this training, we give you the definition. It's like a card. It's easy, and that's the point of it, to make it easy for you not to miss really horrendous signs and be safe, and for the patient get the maximum benefit of the conservative management before we consider surgery. So I'm going to show you one more thing that I think it has very relevant to what you guys are doing. You remember that we said in open surgery, we turn those muscles to scar? What can you, as a physical therapist and occupational therapist, what can you do with this scar? Really not much. There's not much you can achieve with scar tissue. One of the problems as well with the surgeries, open surgeries, once we cut the muscle tendon, we interrupt, you're all familiar with the Golgi tendon apparatus and the muscle spindle, specialized muscle that when you cut the tendon, they don't send a feedback signal that you contracted enough. So what does the muscle does? Go contract. It never gets a signal that it's enough. It goes to spasm, and Those people who have had spasm, they know how horrendous this is. That is why they cannot ambulate. This patient, after the surgery, it take him a long time to become independent because for all that spinal levels, we interrupted this internal mechanism. And for that reason, this is truly what I'm proud of, is this slide. 96% of our patients ambulate within the first 24 hours. Even those 88-year-old patients after 4-level fusion, they ambulate within 96% of them within their first 24 hours, so they can go home. In comparison, after open regular surgery, less than 5 to 10% of the patient ambulate within the first 48 hours. So we just flip that. And the reason we flip that is as simple as this slide here. They don't have to deal with that. Now, the risk of infection is obviously for us is 1/20 of open surgery because we don't cook the muscle to stop the bleeding. We don't cut them to start the bleeding to start with.
Right.
So, and there is no dead tissue for the bacteria to thrive on. So our risk of infection has been 0.2 versus our open surgery has 3 to 5% risk of infection. So 1/10 to 1/20 risk of open infection. And after 1,500 cases, not a single take back to surgery.
So what imaging is required prior to surgery and post-surgery with preferred timeframes?
Well, first of all, our protocols requires us to have something that let us look at the nerve spinal cord within a year before the surgery. That is either MRI or CT myelogram. But within 6 months before the surgery, we're required to look at the bone because that is where I'm going to put the screws. I need to know at what angle, what size screws or hardware I can put in. So myelogram or MRI within a year before the surgery and a CT preferably within 6 months before the surgery.
What about after surgery?
Our protocols, something is called evidence-based medicine. Everybody is crazy about it, but you would be surprised. Less than 5% of the practitioners really do that. What do you need, Alyssa? What do you need to have evidence-based medicine? You need evidence.
You need evidence, studies.
Yeah,
Yeah.
evidence. So
Facts.
we get we let the swelling go down. Then we get the baseline CT within 4 weeks after the surgery. Then we know what's our baseline. Then we used to get X-rays in 6 months and CT in 1 year because nobody ever would see fusion within 4 to 6 months. Now we notice we do see fusion within 4 to 6 months with our surgery. So we get now 4 to 6 months CT and a year, and after that, every 6 months a CT until we see the fusion. And that is what evidence-based medicine is. Once we see the fusion, then we, for all practical purpose, we eliminate most of the limitation, most of the daily activity limitation that, again, it's as protocol we have put in place, and those will be forwarded to you to look at. Most of that is common sense, but as they say, common sense is not very common.
It's not common.
One of the danger of our surgery is that patients feel so good, so fast, they do things that can be considered crazy, like putting a 1,700-pound swing set for their grandchild together 3.5 weeks after the surgery, or
Semi-truck tire.
changing a semi-truck tire all by themselves about 3 weeks after the surgery, and so on. And the reason they feel good is because we don't cause too much damage and the screws are holding them in place. And the screws most of the time are fine. Sometimes you can break them. But what happens if you put a tremendous amount of pressure there, like putting a screw in a drywall, screw is fine, but you have a gap between the drywall and the screw. Now, this is important, and I know that most of you have gone through that process. Now, and what I'm going to talk about is the biomechanic of the spine. This is I can talk about that for days to you, but
would it be okay? I do have a couple more questions, and then would it be okay if you talk about biomechanics after?
Yes, go ahead.
Okay, so before surgery, is physical therapy required?
Absolutely, except somebody has acutely progressive symptoms, and those symptoms are bowel, bladder incontinence or weakness.
Okay.
If almost everybody else get physical therapy, occupational therapy before the surgery.
Including patients maybe that have been in like a car accident or something.
That is why we get those films, making sure that we are not dealing with the instability of that nature. If there's instability, obviously surgery. But again, that is less than 3% of the patient.
So is there anything that you think these physical therapists should know, or what would make it easier for them to discuss the surgery with their patients ahead of time?
There's a lots of things, first of all, setting up the expectation, preparing them for the surgery, teaching them that what activities are more demanding and less demanding to the spine. And this backs us to biomechanics of the spine. Nobody knows biomechanics of the spine more than you. Now, let me just give you an example. Everybody is familiar with the concept of a crowbar, correct? You have a long arm, you have a short arm. In our spine, the long arm of the crowbar is our torso. The short arm of the crowbar is the depth of the vertebral body. Those studies are done. If you bend, you put almost 1.5 metric ton of pressure on those screws that we put in. Okay, so you want to avoid bending, twisting, lifting. Twisting is even worse. Everybody knows if you have a wet towel, how do you get the water out of the towel? You twist it.
You wring it.
And that is exactly, the worst action for the spine is twisting. And that is why almost if you go to bottom of it, every time they do something that's painful, it has one of these elements, bending, twisting, lifting. Now, your job is to show them how they can do beautifully daily activity and avoid as much as they can those biomechanically unhealthy action within the first few weeks. Now, one of the hardest thing for them is transition. And the transitions are, as you know, is going from one position to another.
Like getting like the log roll, getting out of bed.
For example, or even getting into a car or out of a car. Going from standing to sitting to bed and so on and so forth. And as well, about, one of the things they always ask me is about, what about, how can I live without bending? I think all of you are expert to teach the patient they can truly live okay with very little, limitation and avoid bending and twisting. And there are ways to go around it. One of the example I tell the patient, I can bend and tie my shoes, or I can put my foot on a step or something else, tie my shoes, or even better, I can have shoes that they don't need tying.
Velcro.
Yeah.
Yeah, here you are. You see there?
Crocs.
So there are ways, but none of that is really natural for somebody who has never had to deal with that.
It's all about practice and readjusting.
Education.
So for you guys, are there any questions that you want to ask Dr. Abbasi before we get into the biomechanics?
So I do have all the protocols and I will distribute them to everybody and make sure everybody has a copy, and then they will be on our side as well. No, I think, does anybody have any questions right now?
I want to show you just one study.
If any questions come up later, you can email them to me.
And by the way, we have we have tremendous amount of educational meetings. Tomorrow, we have another meeting where we talk to a doctorate of physical therapy about what all the things he can do. So put me out of business. And believe me, I won't be out of business, but I'm okay. If he can help a patient, I shouldn't. Okay. And that is the goal, that, reducing the number of the people who need my expertise and increasing your output of your expertise for patients' benefit. This is one of the things I'm going to show you. And if you forgot everything I told you, just memorize this slide, because that is exactly shows who we are and why we are so successful in what we do. This is about 400 patients in 1 year in one hospital. And this, there are 7 surgeons in this study. And by the volume, 80% of the surgeries are TLIF, the blue line. As you see, when the BMI goes up, the time on the anesthesia and time of the surgery goes up, and every other complication outcome directly correlates with that. Comorbidities, pneumonia, blood transfusion, hospital stay, return to surgery. All of that correlates with the time under anesthesia. And it makes sense that with higher BMI, that you see that number goes up. The red line is a minimal invasive TLIF in the hand of somebody who is a star, who is the ace of MIS TLIF. Even in his hand at BMI of 37, that surgery becomes more dangerous because you have to work deeper in a hole. You have to do a traditional surgery deeper in a hole. Look at us here. OLIF makes absolutely no difference. I can do this surgery on BMI of 50 and not break a sweat, because once the tube is in, I'm not really relying on it, working on the deep of the hole to do a traditional surgery. This is a completely different surgery. So we have collaborated and showed that even on the BMI up to 60, we can do this surgery. We know downside regarding patient's outcome. Obviously, these are not the patients we are going to do in your place. The surgery is not about me. The surgery is about the whole team that is prepared to provide this kind of care. In your place, I don't believe we will have any problem if your anesthesiologist can put them to sleep. I feel comfortable doing it there. We have good result. I just came back from Oman. We did BMI 48 and so on, which is for other open surgeons. It's a big deal doing those surgeries, not so much for us. So I'm going to stop here. And please, if you're interested, Amanda will forward to you links to our other educational. Look at that. It's 4 o'clock. Exactly.
timing.
Perfect timing. So
And
I'm
they
going
have
to-
some patients too coming in.
Yes,
before.
yes. So I thank you so much. Thank you for waiting. Individually, please feel free to connect to us. We have tremendous amount of other information that we can provide and educational events. But if you have 1 or 2 questions, I'm happy to answer it now.
Look, you're very good. No questions at all.
Wow. First time
Thank
for
you.
everything.
Thank you, Dr. Abbasi. Thank you, Amanda. Thank you, everybody. Appreciate it.
Thank you very much.
Thanks, guys.
Bye-bye.
Carrie has my email if you need it. If you need any documents or anything like that, reach out.
Thank you,
Thanks.
Dr. Buffy.
Bye-bye.